Good morning, good afternoon, good evening, everybody. Hello, everyone. It's 9 a.m. in Seattle, 6 p.m. in Paris, 6 p.m. in Marseille. And it is my great pleasure to welcome you all to this first IACH Journal Club for the year 2025. I'm Mohamad Mohty from the Sorbonne University and Saint-Antoine Hospital in Paris in France. And as we embark on this new year, 2025, I'm very thrilled to see so many familiar faces and new members joining us to the IACH activities. And among all the activities, I think this journal club has been always a cornerstone of knowledge sharing, where we try to bridge research and practice and foster an environment of critical thinking and innovation. And this year, our goal is not only to continue this tradition, but also to deepen our impact by exploring some groundbreaking studies and have maybe more interdisciplinary conversations. And you will see the topic chosen for today, I think, reflects this commitment to advancing the frontiers of hematology and specifically hematopoietic cell transplantation. As usual, I would encourage everyone to participate actively, share your insight, your comments. Please ask questions, because obviously the strengths of this journal club lies in the diverse perspectives and expertise that each of you brings. So let us begin this year with the spirit of curiosity and collaboration. And the paper selected for today is a paper by Dr. Masumi Ueda-Oshima, published in Science Translational Medicine the end of 2024. And we are very fortunate, privileged, and honored having with us to discuss this paper the senior author, the famous Dr. Rainer Storb, who I think is among the founding fathers of bone marrow transplantation, and we owe him a lot. And you may remember a couple of years ago, he was our first giant in hematology as part of the Standing on the Shoulders of the Giants series. And his interview was already published, and you can look into it in Clinical Hematology International, the peer-reviewed journal of the IACH. And to discuss the paper, we have another expert in the field and a friend of the IACH and supporter, namely Professor Christian Chabannon from the Institut Pauli Calmette in Marseille. And Rainer and Christian will discuss this paper. I'll do my best to moderate. You can see the abstract of the paper. It's a very unique study, because the authors managed to get blood samples from 16 related donor-recipient pairs at a median of 33 years, 34 years, going up to 45, 46, including the longest surviving HCT recipient in the world. And would love to hear, to have some good news about this patient. And in addition, for 11 of the 16 pairs, a donor sample from the time of transplant was also available for comparison. And using these samples, the investigators performed ultrasensitive duplex sequencing of genes which are recurrently mutated in myeloid malignancies and clonal hematopoiesis. And I'm sure many members of the audience are familiar with this, because whenever these days we have a newly diagnosed myeloid malignancy, we have to obtain this famous NGS panel and look into these recurrent mutated genes. But also, the authors here looked into a set of functionally neutral genomic regions, which would be representative of the human genomic content at large. And of course, this is quite unique. You can see a schematic design of the study. The recipient, the patient who received the stem cell transplant from the donors, the stem cells, the samples were collected. Some of the samples, 11 out of 16, were available from the time of transplant. And then, of course, from later on for the 16. And the range is quite long, from 6 to 46. There are some beautiful figures and quite actually straightforward to understand. So I selected a few of these figures. On this one, actually, gene which we would recurrently find mutated in myeloid neoplasm, the so-called AML panel, were actually already detected in all healthy donors, even in the youngest ones. And they have multiple exonic clonal hematopoiesis variants in the AML panel. And of course, as anticipated, there was a trend toward a greater number of unique CH variants with increasing age, and we'll discuss this. The authors also compared the tempo of change, actually, over time in healthy donors, the so-called normal aging, versus what's happening after transplant, because you would assume maybe the transplant phenomenon is going to create a very special or specific environment that would have negative or positive impact on the process. And actually, there was an increase in the overall acquisition of mutations in neutral region of the genome with age, and clonal expansion occurred more rapidly in genes associated with AML rather than random genomic regions. The authors also compared the shared variants in donor-recipient pair post-transplant, and actually they also could investigate whether individual mutations pre-existing in the donor expanded to a greater degree in the recipient compared with the donor after transplant. And my personal summary after reading this paper of a couple of times are shown here, and these are items that we will discuss with the Dr. Storb and Dr. Chabannon. First, clonal hematopoiesis is present in all donors, even as soon as young as 12 years old. And these mutations were commonly associated with the classical culprit, I would say, DNMT3A, TET2, ASXL1, which are linked to myeloid malignancies. The mutation rates in recipient post-transplant were similar to those observed in donors, showing no significant increase due to the transplant process. And this suggests, and it's an important piece of information, I put it in red, that transplant does not inherently accelerate mutation-driven clonal expansion in the recipient. When it comes to shared mutations, most mutation did not expand significantly even decades after transplant, although they could, some of the mutations were transferred from the donor to the recipient. And the expansion of these shared mutations was modestly associated with the time elapsed since the transplant, but not strongly with donor age. And I believe that obviously most of us were convinced about this. The study highlights the immense regenerative capacity of the human hematopoietic system, even decades after transplant. But also, I think, and that's really important to do these long-term studies, it provides reassurance that clonal expansion due to donor mutations is rare and does not significantly increase the risk of malignancy in long-term survivors. So I'll stop here, this introduction. Again, Rainer, Christian, thank you for joining us today. I know it's relatively early morning for you in Seattle, but we're very honored having both of you with us. And as usual, my first question goes to the non-co-author. So this is Christian here. And actually, Christian, you were among those guys who wanted to select this paper for this discussion. Why do you feel this paper is important?
Well, thank you, Mohamad and Rainer. It's truly a privilege to have this conversation with you. And to answer your question, Mohamad, I think one aspect was I would qualify this paper as a purely academic production. So this is not to say that it's not interesting to look at randomized trials comparing different strategies that integrate innovative drugs, immunotherapies, and so on. But this one is really an academic perspective on a treatment that has been mostly developed in academia, stem cell transplantation. And unfortunately, I guess, will not generate major revenues, but allow us to explore, I think, a fascinating question, which is whether or not we exhaust the hematopoietic system in the process of stem cell transplantation. And the other reason I was interested in is that in parallel with my clinical activity, I'm still interested in stem cell biology and animal models. And there is an ongoing controversy on the relevance of transplant models especially in rodent models, because these are non-homeostatic conditions. What we observe about stem cell biology, is that relevant or not? Is that what happens in normal conditions? Do stem cell renew the same way after stem cell transplantation, and so on? And obviously, the third aspect is that over the last decade or so, there has been a large discussion in the transplant community on what type of donor should we select, especially in the context of haploidentical transplantation. There is a trend to select younger donors because it's easier in some conditions. So I thought the observations in this paper were quite refreshing and also quite instructive in terms of we should not discard, if I can say so, all the donors.
Excellent. Thank you very much, Christian. So, Rainer, can you walk us through this work? I mean, what was the original idea? What motivated to do this work? And maybe a brief summary about the technicalities that you have put in place.
Thanks, Mohamad, for inviting me. It was actually a fishing expedition. The idea was, the initial hypothesis was that there would be an enormous amount of pressure on the transplanted hematopoietic cells after the transplant has taken place. When you do a transplant, you transplant perhaps less than 1% of the donor's stem cells. Let's say a donor has 100,000 stem cells, you're putting in 1,000 or even less. And we hypothesized that this enormous pressure would, over the years, lead to expansion of clones that were present in the donor, which were, say, associated with myeloid malignancies, that these would expand enormously. And that was the initial idea. And so to do this, I had this idea for a long time, but then a former fellow from the Fred Hutch and University of Washington, Jesse Salk, set up a company that developed this ultra-sensitive sequencing technology. The company is called TwinStrand. It's a local company. We got together with him and we said, what if we give you these samples? Can you help us? And he said, sure. And so we recruited a retired nurse, Judy Campbell, who worked with us for 45 years. We got her back and said, Judy, you know all of these old patients and their donors. Could you do us a favor and call them and ask them to send us blood samples for these studies? And Judy called a total of 62 donor and recipient pairs, and they all sent us samples. So we still have a lot of untested samples right now that are undergoing further testing. And we decided to publish the data on the first 16, on 11 of whom we had pre-transplant samples in the donors. And that's the essence of the paper that you just so beautifully summarized. In other words, the paper showed that our hypothesis didn't really hold water. We did not see an increased mutation rate. We did see myeloid malignancy associated mutations, as you pointed out, already in the youngest of the donors, who was 12. That clone was transplanted and did not expand significantly. We saw, as everybody knows, that with the age of the donors, the number of mutations increased at a rate of approximately 2% per year. Our oldest donor in the study was 84, and I looked at the recovery of blood cells after transplantation and found that in the recipient, who was his, I think, 41-year-old daughter, the hematopoietic recovery was the same as if the donor were 12 years old. So it looks like even an older donor is perfectly capable of donating cells to a younger recipient. And despite the fact that this donor had multiple mutations, they did not expand preferentially in the recipient. So I think what this study suggests, based on these small numbers, is that young donors and older donors can be used for transplantation, that there is no risk, at least no apparent high risk, of selective, if you wish, expansion of an abnormal clone. So that's, I think, in essence, what surprised us. We currently, as I said, are expanding the observations. And we're also looking at telomere changes along with a laboratory in Vancouver, British Columbia, Peter Landstrop's lab. And we're looking at epigenetic changes in donor-recipient pairs as well as immunologic studies with a laboratory here at Fred Hutch. So I think it gives us, in the end, an overall impression of how does actually a small number of transplanted cells do on the long haul in restoring hematopoiesis.
Thank you, Rainer. Very clear. And actually, this is the beauty of everything we do, because actually we do this research because we don't know the answer. And sometimes the answer is totally opposite to what we would have expected. And I think it's a very important message to the younger colleagues in the audience, because these days you write a grant, and we'll have a webinar on how to write a grant. And they ask you in the grant to ask the question and to know the answer in advance. Otherwise, you won't get the grant. And this is a very nice example that research by definition is unpredictable.
Yeah.
So before going into some details, Christian, one question about whether in your practice today, when choosing donors, how do you feel reassured with the conclusion of Reiner and the paper saying, because the recommendation is to use the youngest donor. And I think we had an educational session at the last ASH meeting. I had the privilege to be there, and the consensus was try your younger donor. And actually, doesn't look like that it is a matter of concern. Obviously, the recommendation is not to screen for clonal hematopoiesis, and I think it's good news. This is reassuring here. So what are your thoughts about it?
Well, you know, a number of years ago, I think it was 2017 or 16, we published a paper in BBMT, as the journal was called at the time, and we looked at, I believe, 1,500 or thereabouts donors of all ages. And we asked the question, is there a difference in donors above age 60 versus those below age 60? It was a binary kind of thing. And we looked at the recovery, the tempo of recovery of neutrophils, of platelets. We looked at acute graft versus host disease, chronic graft versus host disease, relapse rates, and non-relapse mortality. And I forget what else. And what we found was that all of these things were absolutely comparable. There was no significant difference. The only difference, we focused in this paper on patients getting peripheral blood stem cells, but we also did a separate analysis on marrow, and the results were very comparable. The only difference we found was that older donors mobilized a few less stem cells than younger donors, but it didn't affect the hematopoietic recovery or anything else that I just discussed. So overall survival was also very comparable. And so my conclusion, based on this relatively small number of 15 or 1,600 or thereabouts, was that, well, it doesn't matter how old the donor is. If there's no other donor available, use an older sibling or an older haploidentical parent or an uncle. That's my conclusion. We're currently looking at updating the information because the cutoff, I believe, was 2015. So we had a 2-year follow-up. I understand that, yes, there are differences in regards to analyses done by EBMT, I believe. There was one paper where it said it doesn't make a difference. Another paper said, well, it did make a difference. So I think I would like to revisit this, and we're doing this right now. And my feeling, basically strengthened by the analysis in the recent Science Translational Medicine paper, is that it doesn't matter how old the donor is. Stem cells are there in huge numbers. They don't need them all, as we can see when we do a transplant. I mean, our oldest patient is now 53 years after transplant, perfectly normal hematopoiesis. And that's based on a transplantation of maybe 1,000 cells, stem cells. So I think older donors are perfectly fine. I think that's my bias at the moment.
Christian?
No, I think that the data are very reassuring in terms of quality of hematopoiesis, even in older donors, which is one, but only one criteria when you are doing the workup to identify and select your donor. So in regards to your question, Mohamad, that my institution, we have decided that we would prefer to select younger donors. And in fact, for all those potential donors who are older than 65 years of age, which I personally believe is very young, we tend not to select those donors. But obviously, there is some, this is somewhat arbitrary to decide on this cutoff. Obviously, there are many other reasons that lead to select another donors, including a younger donor. And because we have a strong program with haplotype mismatched transplantation, it's very easy to get access to the children for most of the potential recipients. But again, it's very reassuring to see that whenever you come to the decision to select an older donor, stem cells are still very fit, even at age above 80, as shown in the first patient in this series. The other important issue is whether we should or not look at the genetics of the donors, systematically search for clonal hematopoiesis. We do not do that. There has been two editorials, pro and cons, published a few years ago, I think in the Journal of Clinical Oncology. I'm not absolutely sure, but I think that was there. Of course, one arguing for, in favor, the other arguing against. So we don't do it systematically at my institution, but very often now incidental findings lead us to consider mutations that we discover in donors, and whether we should prefer a donor harboring a mutation or not is really a difficult question to answer. Once again, I think the data shown in this paper shows that it's quite reassuring that well, first of all, we probably all have mutations that accumulate at a slow pace since the time where we are born, and two, that it does not predict full leukemia in the recipient. Obviously, I think we will discuss that, there is a bias in this small group of patients because we are only looking at long-term survivors. So it does not give us a robust conclusion as for those patients who do relapse early or develop complications quite early after transplantations, but I'll let Rainer comment on this aspect.
Thank you, Christian. So let's go into some questions we are receiving. And one question, Rainer, you may wish to address is that among the 16 donors, 14, the majority, actually you use the traditional bone marrow, unmanipulated bone marrow. Only two, I think probably the most recent ones, had peripheral blood. Do you feel that the source, whether unmanipulated bone marrow or GCSF mobilized hematopoietic cell, is going to play a role or can impact these results?
Well, I don't really see any reason to believe that there is a difference between those two modalities. Admittedly, we have not looked at those because all of the early transplants all over the world were bone marrow, right? And it was only in the late 1980s, not that long ago, that peripheral blood stem cells were introduced and have become the preferred modality of transplantation. But I don't personally think that there's a difference.
Thank you very much. So the other question, so Christian, my personal best guess is that we don't see these differences because actually assuming a myeloid malignancy will appear at some point, actually it's not a single hit process. So we need multiple hits, and having a mutation is not sufficient to induce whatever malignancy. So that brings me to the question, and again, it relates to the fact that these are the oldest transplanted patient, where I would say the conditioning regimen was relatively homogeneous, BUSI, Cy-TBI. The GVHD prophylaxis was also quite well standardized, which is not, I would say, anymore the case these days where we have a huge variety. Do you believe that these different factors, which are, because the stem cells infused are going to be in this environment, may influence negatively these results. So it's just pure speculation.
I don't think that the conditioning regimens should affect what's being seen later on, because they're done when the transplant goes in and the stem cells are not affected. Where I do see a possibility is in the most recently heavily used post-transplantation Cytoxin on days 3 and 4. That effect is at this point still unknown, although personally I don't think that cyclophosphamide does have much of an effect on the on secondary cancers, for example. We, not that long ago, published a paper on several hundred aplastic anemia patients conditioned with cyclophosphamide and couldn't really see any increased incidence of secondary tumors other than these chronic GVHD-associated non-melanoma skin and oral cancers. So I don't know, that question is unanswered and should be looked at, whether or not the post-transplant Cytoxin given this briefly after the transplant does leave a mark on the stem cells. That's the only one that I can see to have a possible effect.
Christian?
No, I fully agree. One of the questions I had was there are a number of publications that suggest that the marrow microenvironment may actually be damaged in transplant recipients, not only because of the conditioning regimen, but because of the underlying disease as well as prior treatments. And so again, engraftment is I would say a dual phenomenon where the quality of stem cells plays a role and possibly the marrow microenvironment plays a role. But again, the data in this paper are quite reassuring. Whether modern treatments, modern conditioning regimens would damage differently the microenvironment remains an open question that would need to study more patients from the most recent period.
Where I could see assessing, and these need to be studied, the currently beginning use of gene therapy in patients with sickle cell disease and thalassemia major, where patients are conditioned with a busulfan-based regimen, for example. That's where I can see perhaps long-term development of tumors, of hematopoietic tumors, due to the fact that there are surviving stem cells that have been exposed to the busulfan. So that's a place I think where further studies are definitely indicated.
So, no, thank you both. And I think this is fascinating, actually. We have a question here from a loyal follower of the Academy, Dr. Doreen Mohamad. And she's asking an interesting question, because usually we just avoid this kind of donor, but she's asking about whether if we have a donor with a history of a solid tumor and maybe breast cancer in remission since 7 or 8 years, would you, based on these reassuring results, select this kind of donor, or this is a different story?
Well, you said 7 or 8 years in remission.
Yes.
I think I would, and what we do is we did talk to our breast cancer specialists who would give us the odds. And if there's no other donor available and the odds are pretty good, and the patient has a disease that does need a transplant, then we would go ahead and do the transplant, definitely. But I think it's an issue of weighing the chances of transplanting metastatic breast cancer in the marrow. I think there was a case years ago at the University of Innsbruck where such a thing did happen, actually. and the patient eventually succumbed to breast cancer that was transplanted. So I think it's an issue of weighing the need for the transplant if there's no other alternative, and if there's no other donor, and if the statistics are reasonably good that the patient, the donor, is in a complete remission, then we would go ahead with using such a donor. But ideally, you would like to avoid that.
So, Christian, well, I mean, in our practice, we would usually immediately avoid and not even, do the HLA typing if we are told that this or this patient, potential donor, has a history of whatever malignancy. Even recently, I think a history of MGUS, monoclonal gammopathy of unknown significance, we would be avoiding. What is the current situation, Christian, from a legal point of view in France and in other European countries? Because my best guess is that we're not allowed to take these donors with a history of cancer, whether it's in remission, cured, or not.
I can confirm that from a purely regulatory standpoint, most European countries contraindicate donors with previous history of solid tumors, solid malignancies, with a few exceptions such as basocellular skin cancer or pre-malignant lesions of the uterus. But with those few exceptions, we would contraindicate. But similarly to Rainer, I think this is a regulatory view, and in real life, we could balance the risks for the donor and the recipient. In our modern societies, we very often do not consider the risk of not doing something, not providing transplant, the opportunity to get transplant, which also carries a risk. We very often disqualify donors who have, for example, autoimmune diseases that are extinct for years, except that if you look at antibodies, you can still find antibodies. Personally, if I was the patient, I think the trade, curing me of acute leukemia against the chance of getting thyroiditis, I would accept the risk of thyroid disease.
Rainer, what is the situation in the US? Do you have these rules, laws, legal issues, or you can, depending on the medical assessment, you can take a donor with a history of MGUS or cured whatever, colon, breast cancer?
Well, again, the MGUS we would not transplant.
Okay, interesting.
If there's a history of colon cancer 10 years back, and again, it depends on the patient. If the patient does have a disease that is otherwise not curable, and if there is no other donor, then I think it leads to an intense discussion that the possibility is that a donor who has had colon cancer 10 years ago and has been in remission would be used. It's a very delicate, and it's a long discussion that I can see already occurring in our patient care conference. So I think it's a distinct possibility that everybody involved is very clear about the situation. Distinct possibility that such a donor would be used.
Excellent. Thank you very much. We have a question which I think, although I think cord blood is not anymore the most widely used source of stem cells. So we have a question whether you believe, based on the results, because you could find some mutations in the youngest patient. Well, actually, the claim that cord bloods are the safest may not be totally true, because you may have also these mutations in the cord blood. And that reminds me, I think a few years ago, I forgot the paper. There was a presentation at IACH where they could find the mutation in patient who had myeloproliferative neoplasm in the original cord blood at birth. There was 1 or 2 cases. I don't know. What are your thoughts on this, Rainer?
Yes, actually, we have seen here the development of AML after transplantation of cord blood in one of our recipients. And so I think cord blood is not necessarily the absolute safest because presumably mutations already exist at such a young age. I mean, so, you know, overall, the recurrence or the development of hematopoietic malignancies in donor cells is a relatively rare event. I think it's estimated to be 1 in 100,000, or I forget, actually. It's a very, very rare event, and it's probably related to the fact that occasionally one of the mutations that has been transplanted gets exposed again, and bingo, you have the development of the heme malignancy. We have one patient who was transplanted 28 years ago for very advanced malignant lymphoma. And she had a donor, she got side TBI, had a donor who didn't mobilize. And so we took the donor to the operating room, took marrow out, and did the transplant. And when we looked at the marrow of the donor, 35% of the cells were 20Q minus. The patient recovered with 35% 20Q minus, and she's doing well now as of 3 weeks ago, normal hematopoiesis, but about 80% 20Q minus cells, including lymphocytes. The donor, interestingly, developed a few years ago thyroid carcinoma, got treated in addition to whatever with local irradiation, developed MDS, AML, and died. So one insult with the irradiation turned the 20Q minus into a malignant disease. But the patient is fine.
The multiple hit theory to induce a cancer.
Yes.
So one last question to both of you, actually. For you, Christian, after this work, what kind of questions you would like to see being asked, and where we're missing some answers, some data in this topic, in this field? And to you, Rainer, the question is, what's next? Because you mentioned that you have now a larger series of 62 pairs. So what would be the next step?
Well, as I mentioned, we have now 62 donor-recipient pair samples. We are looking at aging, epigenetic changes, comparison. Again, a fishing expedition. I don't know what's going to come out of it with a laboratory at the University of Washington. We are looking at B and T cell recoveries in these long-term survivors and their donors with another laboratory here at Fred Hutch. We have been looking at and are currently analyzing the telomere changes with Peter Landstorb's lab up in Vancouver, BC. And so those are the things, again, big fishing expeditions, hypotheses behind it are, well, there are differences, but we don't know what the differences are. And it's a purely descriptive set of studies that we're doing currently. They won't have any, I think, effect on future transplantation technology, but they might give us reassuring information.
Excellent. Thank you, Christian.
Yeah, I think I would expect to read more on the description of these pairs of old donor recipients. Especially, I'm interested in the bias that happens while people age, with their immune cells being less effectively produced and being less functional. Does that have a consequence in the context of transplantation? And looking in a more practical perspective, I'm really interested to further understand and define whether and how we can use the wealth of genetic information that will be coming, both regarding donor and recipients, and whether this has any use, any impact in the context of transplantation. I think we need to define practical and useful algorithms, maybe just leave this away, or maybe integrate some of this information in our decision trees.
Wonderful. Thank you very much. I think we have to wrap up this first IACH Journal Club of the year 2025. And I would like to express my gratitude to both of you and to all the colleagues and friends who joined us today. And again, I would insist a special and profound thank you goes to Dr. Rainer Storb, because Dr. Storb, your groundbreaking contributions to transplantation and hematology in general have really transformed countless lives, and your insight today have been nothing short of inspiring. So all of us at the IACH, we deeply appreciate your willingness to share your expertise, your wisdom, and engage with us in this thoughtful discussion, and guide us with your invaluable perspective. Thank you, Christian. To all participants, thank you for your enthusiasm, the thought-provoking questions, and the global commitment to push the boundaries of knowledge. So let's carry the energy and insights from today forward. And thank you again, and I look forward to seeing you all at our next session. This is going to be tomorrow, actually, where we'll have a post-ASH dedicated to CLL, chronic lymphocytic leukemia. Thank you very much. Take care.
Thank you, Rainer. Thank you, Mohamad.
Bye. And all the best. Take care.
Thank you.
You too. Bye-bye.